Good lineup for you guys today. I'd like to introduce Dr. Brian Kuhn. He's from Banner University Poison Control Center, and he's going to be presenting some illicit drugs and heat emergencies for us.
Excellent. All right, can everyone hear me okay? The last of you that filtered in, if you haven't already done the QR code test, just please scan it there. Shouldn't take you more than a few minutes. Thanks very much. My name is Brian Kuhn. I'm a pharmacist and toxicologist at Banner Good Sam. I work both with the Poison Control Center as well as the Medical Toxicology Department, looking after the patients that we get accepted to our service at both Phoenix Children's and Banner Good Sam. So I would imagine we probably see you all with some sort of frequency. I'm going to have two lectures today. The first one is going to start out with kind of a combined lecture on illicit substances and toxidromes. We'll take a little break, and then the second lecture will be on heat-related injuries. So no disclosures. Really briefly, we're going to kind of run through the Poison Center, the structure, what it is we do, who staffs it, like what it is we do day in and day out, just so you have a better idea of what it is the value could be for you contacting the Poison Center. And then we'll talk about kind of illicit trends that we are maybe sort of seeing in Maricopa County or in the Southwest, and how those relate to the various toxidromes that we always try to categorize our patients in when we do the initial assessment, and then kind of wrap up with different types of withdrawal scenarios, symptoms, and treatments. So if we look at the history of how poison centers began, we got to go back to the 40s or so in Chicago. And there really at that time wasn't any sort of established database for physicians, providers to understand how best to manage poisonings. And a lot of these were unintentional pediatric exposures. These scenarios predate a lot of the modern risk mitigation strategies we have in place right now, like child resistant packaging, education, things like that, that are a really good barrier to prevent kids from getting into certain medications and such. But again, back then, there really wasn't any sort of formal database that any provider could look to as far as understanding or getting guidance on how to manage these patients. So this pharmacist and physician in Chicago decided to take it upon themselves to start to collate as much data as they could. They ended up writing all this information on index cards, and it got actually pretty thick, to the point where it was probably several hundred index cards thick. And what they would do eventually is, once they amassed enough information, kind of word got out, other providers around the country wanted similar information. So these guys would just send out these index card packs to whoever wanted them. And that's kind of how the poison control system worked or developed in the United States back then, almost 100 years ago or so. It got to the point where there was probably in the neighborhood of about 700 of these packs distributed around the country up to about the 70s. And so each of those were ostensibly considered poison control centers. Somewhere in between there, though, poison centers kind of realized that things were getting a little bit out of hand. There was a national organization that was created, the American Association of Poison Control Centers, in the late 50s. That started to understand that just having this pack of cards really didn't constitute a really good public service. It was great for the providers to be able to have this information, but what they did with that information was essentially lost. And so in the 80s, AAPCC kind of mandated that poison centers started to actually account for the cases they were managing with respect to whatever information they were using. So they started to document all these cases in the TESS database system, the Toxic Exposure Surveillance System. Again, 700 poison centers, not all doing the same thing uniformly. The AAPCC recognized this and started to understand there needed to be consolidation. So they basically went from about 700 or so poison centers down to about the low 60s. We currently sit at 55 poison centers across the country right now. But during the 80s was a big time of consolidation of different poison centers into what we know poison centers to be right now. It really wasn't until the early 2000s that all of those poison centers were unified by one single 24/7 toll-free hotline. And this essentially allowed anyone within the continental United States, Alaska, Hawaii, District of Columbia, anywhere from Guam to the U.S. Virgin Islands, as long as it was a U.S. territory, calling that 800 number would get you to one of your poison centers. Before then, you had to call or know the local hotline. So this definitely expanded the services to the public in more rural areas than previously had been allowed. The test database was changed in mid-2000 to NPDS. That's the current database system we use now. The reason I'm talking about why it is we have this database, because I think it is one of the lesser known facts of what poison centers do with the calls that you make to us. It's great. On the one end, you can ask questions, we can provide information, but we gather information on each of those calls. We document it in a database, and it works out such that that is a huge trove of information, of data that we can sift through and actually look at outcomes. We can look at trends. We can do a lot of information. We can do a lot of different things with the information within that database. So that's the reason why I'm telling you, because essentially the system we use now is essentially the only near real-time surveillance system in the world for poison controls or poison control centers. And essentially what happens every 10 minutes, and this happens in the background, I don't see it if I'm on the computer at all, but every 10 minutes or so, basically every active case, any open case we have, irrespective of if it's a hospital case or a home case, basically gets stripped of certain information. All of that stuff gets sent up to where AAPCC is on the East Coast, and it's compared against historical standards. It goes back 2 years and it goes back 2 weeks plus or minus today's date, let's say. And it's doing this every 10 minutes of every single day. And it's comparing certain aspects of the cases we have today against historical standards to see if there's any anomalous data, if there's any bumps, if there's any spikes, if there's any weird trends that appear to be emerging. And the reason we do this is it's a very sensitive, not very specific, but very sensitive tool for potentially emerging public health threats. And this exists and is as robust as it is, because perhaps you're aware, hospital systems don't talk amongst themselves, certainly in near real-time or real-time fashion at all. So what happens at my hospital at Good Sam, we have no idea what's going on at St. Joe's, at COPA, at St. Luke's. We have no idea. But if those providers are calling the Poison Control Center, we become that central point of contact to get information about what can be happening a little bit more distributed in the community, as opposed to what might be isolated to just one institution. So it is a pretty sensitive tool, and we've identified multiple outbreaks, the methanol contaminated hand sanitizer on the res during COVID. Chicago has a great example where they identified cases of synthetic cannabinoids that were contaminated with a rodenticide, patients showing up with terrible coagulopathies, no reason to have it. The only common piece was that they had smoked spice. The poison center with the health department kind of worked in concert and found that there was a dealer who had cut the product with some long-acting anticoagulant rodenticide. Mail order pharmacies that are mailing medications all over the country where a specific drug error or a substitution was made. And those different poison centers were receiving phone calls from, their area. But because those represented anomalies relative to what historically had happened, they were able to relatively quickly identify that this drug error had occurred. So there is significant value in contacting the poison center far beyond getting the information you need as a provider to understand what exactly the scenario is you're dealing with, how to manage it, what symptoms to look for. We're definitely getting information that we can use as this, near real-time public health tool. So like I said, we're 55 poison centers across the country. That's more centers than there are states. There are certain states like ours that have more than one poison center in them. There are certain poison centers that don't have a poison center in them. We refer to poison centers as regional poison centers, meaning they cover some discrete territory. So if you talk about Arizona's 2 poison centers, The Banner Poison and Drug Information Center in Phoenix covers Maricopa County. The Tucson Center, which is the Arizona Poison and Drug Information Center, covers the other 14 counties of the state. We were both started in the late 70s, and when that distinction of us taking the one, them taking the 14 counties was established, there was a much more equitable spread distribution of the population. Obviously, a lot's changed, and that's reflected in our call volume. We do about 2/3 or so of the call volume relative between the two poison centers. But if you're in a state that doesn't have a poison center, there is a center that is designated to cover that region. So if you're in the Dakotas, Montana, Idaho, Hawaii, Maine, Alaska, they're all covered again by that 800 number where it routes you to your appropriate regional poison center. Across all 55 poison centers, they're staffed essentially by nurses and pharmacists, and we always have toxicology backup. Our center here looks a little bit different than some other centers because of the medical toxicology fellowship, but ostensibly it's nurses, pharmacists that can escalate cases to toxicology physicians as necessary. Even though we are differently degreed professionals, one of the requirements that the AAPCC has is that we're required to become certified specialists in poison information as nurses or pharmacists. And this is the way that the national organization levels the playing field, if you will, between the education, the experience of nurses and pharmacists. And this is one of the requirements. So, we have to be 24/7, we have to be free, we have to have language interpretation, we have to do the toxico surveillance piece, and we have to have C-SPI nurses and pharmacists running the poison center. So what do those nurses and pharmacists do day in and day out? I mean, I watch a lot of YouTube and stuff, but in between those clips, that's all I do is I answer the phone, I wait for the phone to ring, and you have no idea what's going to be on the other end of that line. 9 times out of 10, it's kind of the same sort of scenario, but man, that 10th time just throws you for a whammy. But that's essentially what we do, and we do it pretty frequently. So on average, the last few years, we've managed about 50,000 incoming calls a year. And we divide these calls into 2 different categories. We divide them into what you would be calling us for most likely. These are human exposure cases. And I make the distinction human exposure. For some reason, we get a lot of animal exposure calls. I shouldn't say for some reason. There are 2 poison or animal poison centers in the United States that I'm aware of. One out of Illinois, one out of Minnesota, and both of them are fee-for-service programs, which essentially means you have to put your credit card in as you're dialing the phone before you ever get to talk to anyone. And I think it's like $65, $70 or something. And apparently that's a threshold. Apparently a lot of pets do not want to cross. So we will get those phone calls pretty frequently, almost to the tune of about 2,000 cases a year. Now, we're not trained veterinarians. We don't know much about vet tox, but most animals tend to do sort of a similar thing as kids. They're just sort of exploring their environment. They tend not to get into too much of any one particular thing. And if we have information in our database, we're happy to share it with whomever we will. But the bulk of what we do are these human exposure cases, about 40,000 a year. The other sort of 20% of calls we get are these information calls. And an information call is essentially anything that doesn't meet the criteria of a exposure call. And an exposure call is where you have a patient and a substance and some form of a route of exposure, whether it's ocular inhalation, dermal, oral, what have you, parenteral. But there has to be sort of that interaction between a patient and a substance. And if we break down who's calling us with those human exposure cases, we can kind of say that about 80% are calls that come from a non-healthcare facility. So some residence, work, vehicle, school, jail sometimes. It's basically someone calling, their child got into bleach, someone took a double dose of their medication, both parents gave the same medication to the kid errantly. I mean, just sort of typical scenarios that I'm sure, you're familiar with. The good thing is, and this becomes one of the points of pride a lot of poison centers point to, we're actually able to manage the vast majority of those home-based calls at home. Part of that is most exposures tend to be fairly innocuous. They do tend to skew more towards pediatrics. Pediatrics don't have the intent to either ingest large quantities or typically just don't have, generally speaking, access to potentially harmful products. So this becomes one of the significant advantages of having a poison control system as part of your broader healthcare system, because there's significant cost avoidance when a poison center system is involved, to the tune of about $1.4 billion in avoided healthcare costs per year across all 55 poison centers. There is also outcomes data. So if you're a hospitalized patient and your medical team involves the poison control center, those patients tend to do substantially better than patients whose medical team did not involve the local poison center. So decreased length of stay, decreased adverse events, decreased overall healthcare utilization. So it's kind of a win-win to incorporate subject matter experts like ourselves into these sorts of cases. So yeah, only about 8% of home cases end up needing to be referred into a healthcare facility. And those healthcare facilities essentially fill in the other 15-ish% of the human exposure calls we get. And those calls can range from a physician just kind of outlining the scenario they have in front of them. They got an 18-year-old who took this 2 hours ago. These are the presenting symptoms. These are the initial vitals. These are the labs. This is what's come back. This is what's still cooking. I'm going to watch them X amount more hours. What do you think? Have I missed anything? Is this an agreeable plan? So a lot of times it's just sort of a double check of what their plan in their head already was. And we find a lot of times, because we have access to the EMR that Banner uses across their entire healthcare system, and we'll go into the ER note and we can see that that physician's documented that interaction with us. So whether it's a little bit of CYA for them or some sort of risk mitigation from a liability standpoint, it's unclear. But again, they're engaging subject matter experts to get confirmation of their clinical plan. And it can go all the way to the other end of the spectrum, where that physician either needs to transfer that patient over to our hospital for an admit or a consult, or let's say they're at an outside facility that can transport and they just have no idea how they're going to be able to manage this critically ill, complex patient. So it really runs the spectrum. That said, it is 100% voluntary that physicians do it in this state. In fact, in most states, there's almost no requirement or threshold that obliges a physician to contact a poison control center for any type of specific case. So it is 100% voluntary type system. So, you know, the number that we capture, 50-odd thousand calls a year, is obviously a fraction of what literally happens day in and day out. We end up making about 90 to 100,000 outgoing calls. So when we get the incoming call, again, irrespective of home or hospital, we're going to do some sort of follow-up. And probably one of the best examples are our scorpion envenomation patients. You know, we get a lot of people who are moving to Arizona from other states. They have no idea about our venomous critters and such. You know, you start to get the initial symptoms, the pain, numbness, and tingling. It's crawling up your leg. People are going to panic, obviously. They're going to go to Dr. Google. Dr. Google is going to send them down some terrible wormhole of misinformation or just the most dire situation that could exist. And they'll eventually find our number and give us a call. And what we'll do is we'll essentially call them for some fixed amount of time, maybe 2 or 3 times, just to kind of walk them through that process. And we find that that substantially reduces unnecessary ER visits. So again, cost avoidance is kind of one of the underpinnings of why the Poison Center, you know, asks for federal funding year after year. But if you look at, and I kind of talked about NPDS and how we sit on this trove of data, our 40-odd thousand human exposure calls plus the other 54 centers calls every year amounts to about 2.1 million cases. And again, there's a ton of information in there, whether it's epidemiology on rattlesnake bites or beta blocker overdoses or pediatrics getting into the water absorbing beads. Now the big thing are these Zyn nicotine pouches. We were tracking the Tide Pod challenge, the Benadryl challenge, the cinnamon challenge, all that crap. That sits in our database. And really no one else has the same volume of cases that we do. And there's a lot of federal agencies that have direct visibility into this database as well. So Arizona Department of Public Health, Maricopa County Department of Public Health, the FDA, the CDC, and probably 8 other federal agencies see our database in the real-time status as we do. These are some examples of the information calls that come in. We still do a little bit the COVID hotline, but Zika helpline, the immunization helpline, rabies risk assessment, disease reporting line. We do a lot of ancillary stuff. Just because we're healthcare professionals, we're 24/7, and it just kind of helps fill in when the health department's closed after 5 and on weekends, holidays, that sort of stuff. If we look at the distribution of the patients represented by the calls that come into the Poison Center, we can kind of see 2 age groups represented pretty dramatically. And the first one, the young, pediatrics here between, 1 and 2 or so. That's, kind of our bread and butter. We get a lot of calls from parents because, again, kids are, unintentionally exploring their surroundings, getting into things like that. And then we get the demographic here of, 20s and 30-year-olds doing 20 and 30-year-old type activities. Yeah, but if we look at the substances involved in those calls across all ages, and I'll show you another slide here in just a little bit, our top substance we get a call in regards to are bites and stings. That probably shouldn't come as much of a surprise. We do about 8,000 or 9,000 scorpion stings between the 2 poison centers and about 550 snake bites per year, again, between Tucson and our poison center. But the other products here, analgesics, household cleaners, antihistamines, cosmetic, personal care products, antidepressants, cardiovascular, sedative, hypnotics, antipsychotics, stimulants, and street drugs. And that's a pretty common list of if you kind of went around where you live, go into the medicine cabinet underneath the kitchen sink. These are all very common products that most anyone would have access to for an intentional or unintentional exposure. But if we look at the unintentional pediatric exposures, we can see that instead of the top substance being bites and stings, that's actually down here in the number 7 spot. The number 1 things kids get into are typically the over-the-counter analgesics. I don't know why children's ibuprofen must taste like Rocky Road ice cream. That's my favorite. So they will go through a 4-ounce bottle like nothing, even an 8-ounce bottle. It's pretty remarkable. The good thing is the formulation's concentration is typically low enough that if you have a large enough kid to get into that amount of volume, they're usually by weight never going to hit that, toxic threshold of ibuprofen toxicity. But even Tylenol, children's Tylenol, apparently tastes good. I never had the thing as a kid. I drank my amoxicillin. But yeah, kids love analgesic. But again, you can see the other kind of common products around the house, household cleaners, cosmetics, foreign bodies, toys, things like that. So button batteries, magnets, that represents a pretty large percentage of the call volume that comes into it. And the rest there, these are just, again, sort of garden variety type things. Nothing unique, nothing super special, nothing that most of us wouldn't have in our house right now. But if you look at our substances compared to the other 54 centers, and this actually includes Tucson, even though they cover the majority of the state, they're covering a much smaller percentage of the population within Arizona. Again, it's only about 1/3 of the population of those 14 counties compared to our 62, 63% just in Maricopa County. But the top substance we have are bites and stings. That's about 15 to 16% of our call volume. If you compare that to any other poison control center, theirs is less than 2%. And so that becomes kind of the underpinning of the majority of calls that we take. And again, like I said, we do, 8, 9, 10,000 scorpion calls and 550 odd snake bites. And then you throw in the other weird things, the bees, centipedes, the Gila monster, tarantula hawk, blister beetle. What am I forgetting? Those are kind of the big ones. Yeah, so if it moves or crawls or grows here, it's probably trying to kill you. So we'll eventually get a call on that. But across all of the other sort of top 10 substances, they're pretty equally distributed. We do the same amount of calls as virtually everyone else, with the one exception of bites and stings. So I'll pivot from that into kind of the core part of this first half's lecture, and we'll talk about illicit substances. So, overdose deaths are categorized by the CDC as unintentional accidents or unintentional deaths. And there's a broad category of different circumstances that fit into that unintentional deaths category. So motor vehicle accidents, but drug-related overdoses account for about half of the unintentional deaths, which is the third leading cause of death, or at least it was a couple of years ago, a year and a half ago. And opioid-related deaths within the drug overdose category represent about half of those. So this is kind of the foundation of why healthcare experts continue to sound the alarm on, the epidemic that is currently fentanyl for us in the majority of the United States, but still primarily the deaths that we see from opioids. In terms of where those death rates tend to be going, we can see a pretty sharp increase. A little pointer doohickey. Oh, there it is. I can't see. Can you all see that red pointer? I can't see. I'm going to come over here. We can see that, we think for the most part, like fentanyl has been around since probably the better part of, at this point, 20 odd years. We saw a couple of blooms in the early 2000s. San Diego had a thing, Philadelphia had a thing, West Virginia had a thing, and then it quickly evaporated, but it came back at about 2015. And unfortunately, this doesn't go to prior to 2015, but you can see a steady increase in the number of overall drug-related deaths. This doesn't necessarily tell us specifically opioid contribution to these overdose deaths, but we generally know that on average, probably 75% of drug-related overdoses involve an opioid, and the opioid is probably a significant contributor to that fatal outcome. But we can see a pretty big spike here during COVID. And then we can see, relatively speaking, kind of in 2022 and 2023, that there was a little bit of a leveling, a plateau in the drug-related deaths. And what we see here, there's a bubble line and there's a solid line. The bubble line, or the bubble trajectory, that's the statistical prediction of what mortality should do based on previous trends. The solid line represents the actual numbers. And so when I looked at this in 2023 with 2022 data, it looked the same way as this January 23, where there was a divergence, that there was a decrease from the predicted trajectory of overdoses. So I don't want to paint a completely doom and gloom picture that we're not doing anything, that we're losing this uphill battle. There does seem to be some improvement in at least the fatalities related to drug overdoses, better than what the statistical models predict. So when it comes to the initial approach we have with our patients at the hospital, we uniformly, if not daily, go through and try to not necessarily pigeonhole, but see if we can incorporate aspects of these toxidromes into what our patients are presenting with. Sometimes this works, sometimes it doesn't, but it at least gets the conversation started about what the patient's presenting with and what symptoms of those appear to be tox-related, and if we can associate those tox-related symptoms to a specific drug, because then we can target the type of treatment we want to provide these patients based on that drug-related series of symptoms. So we've got 5 toxidromes: stimulants, opioids, sedative, hypnotics, antimuscarinic, and cholinergic. And so I'll go through some of the illicit drug trends that we are seeing and associate them with these toxidromes, as we can. So we'll start off with opioids. Fentanyl certainly still dominates the landscape right now of what is sort of the most problematic substance, at least from a fatality outcome. Certainly methamphetamine is not going anywhere either anytime soon. But from an epidemic standpoint and like bad outcomes, we just don't really see it with fentanyl or with methamphetamine. And methamphetamine's been around since, the 60s and 70s, and we haven't really seen some horrible trend emerge from meth use like we have with how fentanyl has dramatically changed the landscape of opioid use in this country. So we can have various types of opioids. We can have the prescription products. We can even have some of the over-the-counter opioid-related products like dextromethorphan, the DM, and or multi-symptom cough and cold preparations. We've got these illicit substances. I'll talk about tianeptine. I'll talk about these nitazene derivatives. We'll talk a little bit about fentanyl. We'll talk about metragina. But whatever the product is we're talking about, whether illicit, prescription, plant-based, or what have you, the common mechanism of action that leads to an opioid toxidrome comes from that, this fact that they all have this common agonist activity at the various opioid receptors, the mu, kappa, delta, that we find in various organ systems. I can't talk about fentanyl without talking about some of the contaminants or adulterants that we see in fentanyl. I don't want to necessarily project this picture that our fentanyl supply is somehow more or less concerning than in other parts of the country because of these contaminants. The primary one is xylazine. Have you all heard of xylazine, whether on the news or maybe your patients? No? Yes? Okay. All right. Got some head nods. So I don't know that anyone calls it tranq. We don't call it tranq. I don't think any of our users call it tranq. Frankly speaking, they don't appear to be going to their dealers and asking for tranq. They're just asking for blues or oxys or M's or M30s, just the common vernacular for a fentanyl tablet. I don't know necessarily that our fentanyl user base even knows that fentanyl is something that is to some extent cut into the supply here. It's much more of an issue on the East Coast, it seems. But nevertheless, it's something I think you should all have kind of in your back pocket when you're managing these opioid-related overdoses out in the field, because the clinical effects of xylazine mirror the effects of fentanyl, except it is completely resistant, untouched by naloxone. So xylazine, what is it? It is a veterinarian used and approved in the United States anesthetic analgesic sedative. It is an alpha-2 agonist like clonidine, like dexmedetomidine. And because of that, the clinical effects, the sedation, respiratory depression, hypotension, bradycardia, meiosis, look almost indistinguishable from someone who's under the effects of any opioid, notwithstanding fentanyl. But again, because it's not a mu agonist, it's not going to have any effect when Narcan's administered. It is an uncontrolled product. It is way cheaper than fentanyl is. And we think it's getting cut into the fentanyl supply. Not only, there's no such thing as a pure drug product out on the street. It's always cut with something. It's diluted down with sometimes pharmacologically active substances, sometimes not pharmacologically active substances. This would obviously be one of the active substances. But we think it's cut in because of the mimetic effects that, for whatever reason, the end user who's maybe going to try a little bit, they're going to get a similar sort of experience by perhaps a little bit more of a dilute fentanyl product that contains xylazine. They necessarily wouldn't experience that much of a dramatic difference in terms of the overall feeling that you'd get. That's our presumption. Again, the user base probably isn't as sophisticated to really go after one specific type product. There's so much variability from different sellers out of the street. They're cutting their product with different ingredients. So all that variability just kind of means you buy product A on Monday, it's going to be different than product B on Tuesday, sometimes even from the same dealer. But we think it's there just to kind of mimic the effects of fentanyl. But because the symptoms do mimic that of opioids and it's resistant to naloxone, it becomes one of those scenarios when you're out in the field and you are trying to reverse a patient and maybe you don't get the same sort of bang for your buck with the 2 or 4 milligrams of naloxone. We think this is one of the reasons. And if we look around the country, and see to what extent xylazine appears in the fentanyl drug supply. We can find it essentially all across the country. Not as much, again, in Arizona. It seems to start with higher concentrations along the East Coast, but what tends to start on the East Coast will eventually filter its way to us. So it's probably an inevitability that xylazine becomes a more interesting component or aspect of these opioid-related overdoses to deal with. But yeah, we're essentially seeing it all over the country. M30s, I'm sure you're all familiar. It's a very potent mu agonist opioid, extraordinarily cheap, relatively speaking, probably 25, 30 cents a tablet. Our patients that come to us, whether they're coming in from an acute intoxication or precipitated withdrawal, they'll tell us stories anywhere from 20 up to 120 tablets a day. It's pretty bonkers. You know, fentanyl's got that pretty short duration of effect, quick, rapid onset. You know, they can grab one of these tablets, which on average has about 50 to 100 times the therapeutic dose that most of us would be able to tolerate. But they'll go through that tablet within an hour, hour and a half or so, certainly depending on their tolerance or dependence on opioids. It could be multiple tablets every hour. Obviously, that would be the case if, you're using 20, 30, 40, 50 tablets or more. We think for the most part, the reason that CDC data shows a divergence between the predicted and the actual mortality rates, because the use has changed with the user base. We think when fentanyl kind of came on the scene and replaced heroin, which was principally either being smoked, snorted, but primarily injected, we think the same abuse patterns existed with these fentanyl tablets that the users didn't know was fentanyl, being far more potent than that of heroin. So they were using it the same way, just not knowing that an overdose was right around the corner because, again, of these massively supra-therapeutic amounts of fentanyl per tablet. So just like with COVID, we think, the most susceptible groups of patients were those that had bad outcomes, and those that survived either did so because they didn't undertake the risky use pattern of, injecting or snorting an entire tablet. So we think, or they just kind of watched other people do it one way and decided that the poor outcome that person had was not in their wheelhouse and they were going to use it differently. So nowadays, we tend to find that the majority of fentanyl users are crushing and smoking the tablet. So they'll crush it up, put in a little, they'll cut a little corner off a chip bag, combust it and smoke it through a pipe. And that allows that user to more effectively dose without necessarily overdosing, that can receive the intended effect without sort of going overboard. So I think, we generally think that's one of the contributing factors to not this escalating mortality rate year over year. Obviously, there's other reasons for that, Narcan, education, that sort of stuff. But we don't think there's any impact whatsoever on the numbers of overall users. That probably will always remain to be a relatively static, if not slightly increasing number proportional to the increase in the population. As far as xylazine, how frequently we do end up seeing it contaminated within fentanyl products, we're definitely seeing this increased trend. This data is not Arizona specific. This is countrywide averaged data. So where we see these trends far more significantly along the East Coast, we're still seeing an increase, but not into the teens %. And we don't have any data that xylazine is a specific contributor to poor outcomes in fentanyl users who are using that tranq product. In fact, there was a paper put out the end of last year that looked at fatal outcomes in patients who tested positive for fentanyl versus those fentanyl and xylazine. And for whatever reason, they found the fentanyl xylazine patients died less frequently than the fentanyl patients did. Totally flies in the face of conventional thought. We have no idea. It could be completely anomalous information, but we have no data that xylazine is a major contributor to fatalities nearly as much as fentanyl is. And as we're on this conversation, this topic of drug adulterants, drug contaminants, like I had mentioned, there's no such thing as a pure drug supply unless you're getting it direct from the source. But what's on the street is oftentimes cut, again, sometimes with innocuous products like lactose, sucrose, mannitol, things like that, that just sort of make the supply larger. So instead of selling 100 pills, you sell 1,000 pills. You've cut because you've cut it, some proportion with these, substances. But sometimes we can see pharmacologically active substances. This is a deworming agent that we find in cocaine. Maybe 1 in every 50 samples or so that we test for. And the heroin supply used to have all sorts of crap in it. Some of it we think either accentuated the effect or altered the metabolism or was in there just because it was an extraordinarily cheap product that whoever thought it was a good idea to put it in there thought it was not going to have any sort of dramatic impact on the ultimate experience of someone using that drug. And like I said, here's our example of the anticoagulant rodenticide that we've seen in the synthetic cannabinoids, and not obviously xylazine, but you find, quetiapine, that's Seroquel, diphenhydramine, Benadryl, phenacidins, and it's an analgesic. Diltiazem, a calcium channel blocker, and heroin. I mean, it makes no sense, but you can start to get this picture that when we talk about these toxidromes and we try to put our patients or compartmentalize them based on the symptoms they're presenting with, that presumes those symptoms are indeed only caused by one particular agent, which rarely do our patients ever have just one substance on board. And that doesn't even take into consideration, other disease states, other medications they're on, or just neuropsychiatric disorders that can contribute to the clinical effects that you're managing. And this is just a small list of other known contaminants and adulterants that have been identified in our drug supply in the United States. So there's xylazine at the bottom. Here's ketamine. Here's a beta blocker. Here's Seroquel. Phenylfentanyl, that's a fentanyl analog. We'll talk about these nitazene drugs here on the next slide. These are other synthetic opioids. Chlorpheniramine is an antihistamine. The phenylethyl 4-ANPP, that's a precursor product. So up until a few years ago, you actually used to be able to buy pharmaceutical grade 99.9% fentanyl online. You still probably can. It's just a little bit harder. The countries we were getting that from illicitly have clamped down to some extent. But the precursors and intermediates, the raw ingredients from which you can create the end product from, still have very little restrictions placed on their sale. So we can get these products readily, and we see them popping up on our analytical testing pretty frequently. So the 4-ANPP lets us know that the fentanyl was probably batch prepared in some field by some dude just stirring some weird cauldron over a fire. I mean, that's literally how some of these fentanyl batches are made. This is an NSAID. Here's a barbiturate. Here's a cocaine derivative. So all sorts of different products. There was a study out of the East Coast, looked at Virginia, West Virginia, Pennsylvania, and 2 other states in that area, and found that 55% of the confiscated drug they got off the street had on average 8 pharmacologically active substances detected in that supply. So again, we talk about these toxidromes and we're talking about this sort of in this nice pristine vacuum of one drug causes one set of symptoms, but that's very unlikely the scenario we're going to be dealing with when managing patients. So the nitazene opioid derivatives, as the name implies, these are identical in terms of their mechanism of action. They sometimes can be as potent as fentanyl. Again, we've only seen about maybe 4 or 5 cases of these drugs being detected in our analytical testing. They would respond in naloxone the same way. Symptomatically, they're going to look the same as a fentanyl or morphine or heroin overdose. It's just that the name, just so you're familiar with it, isotonitazine, protonitazine, butanitazine, metanitazine. Those really roll right off the tongue, don't they? But, we expect that if there's some interruption in the fentanyl supply or some of the precursors or intermediates, This is poised just like fentanyl was when the heroin supply dried up. But this is pretty well poised to kind of take over and fill in that vacuum. Because again, the user base isn't going to go anywhere. And if they don't get access to their drugs, they're going to go into withdrawal. So they're going to get their hands on whatever is available to them. So the opioid toxidrome, we've talked about toxidromes already. So let's actually talk about symptoms. And I'm sure we're all pretty familiar. Obviously, at the most broad level, these are patients who are found down hypoxic, anoxic from respiratory depression or arrest, oftentimes with myocardial depression. That's pretty much the classic toxidrome. You can throw in meiosis if you want, but the pupils don't always tell us what's going on. Sometimes we don't get that pupillary reflex from the opioids. Sometimes there's another drug like methamphetamine on board that causes pupillary dilation. So the eyes don't always tell you the picture, but clearly you're going to focus on ABCs. The eyes aren't really part of that. And if that airway is compromised, that's how you're going to initially address these patients. Because the most concerning effect is that hypoxic or anoxia that can occur. So naloxones are a reversal agent. The conventional treatment dose of 0.4 milligrams still exists. It still should be a part of a protocol, but we probably need higher doses of naloxone. Part of what makes fentanyl potent is how tightly it binds to those mu receptors. And that tightness relates to the concentration or the amount of naloxone you would need to kick that fentanyl off of that mu receptor. And so 0.4 might not be an insufficient amount of naloxone for whatever amount of fentanyl is producing those clinical effects. We kind of call that naloxone resistance. We see this sometimes with methadone, with some other opioids as well, like diphenolate, which is a prescription antidiarrheal. But, with fentanyl, methadone, for sure, we probably need higher doses. Now, have we gone the other side of the spectrum? Probably. We have not had the numbers of admitted patients to our or any emergency department with precipitated withdrawal compared historically. And that is the number one opioid-related admission for an alive patient. Now, is it better to manage that precipitated withdrawal type patient as opposed to the dead opioid patient? Obviously. But, finding that sweet spot of what exactly the right naloxone dose is very individualized. On our end, we always say, just do it to respiratory effort and SATs. As long as they're satting well, I don't care that they're still down. Your ABCs, that's why we start there. If they've got good perfusion, if they've got good circulation, got good O2 SATs, deliver me whatever that patient looks like. Otherwise, we'll manage the rest of it for the most part. We do worry about withdrawal, sometimes with single, but definitely with repeat doses, it's more likely to occur. And we can see pulmonary edema as a consequence of naloxone administration. We don't really know who's primarily at risk for developing pulmonary edema. We don't think it's dose of naloxone related. We don't think it's specific to the type of opioid that the patient took. I think it's mostly like this adrenergic surge that happens when you remove the inhibitory effects of the opioid with naloxone that just happens to occur in some patient population. Apart from putting them on some O's and again delivering them to us, we'll probably just diurese them over the next day or two and they tend to do just fine. So it's not really any sort of special consideration or concern in withholding either the initiation or multiple doses of naloxone to get that patient to an acceptable respiratory effort. And then methadone, we can see causes torsades with overdoses. We've got some serotonergic opioids. Typically, we don't see serotonin syndrome unless there's some drug-drug interaction that's involved, and we already talked about the naloxone resistance. So two other opioid derivatives, we're going to talk about kratom and tianeptine. So kratom's this plant-derived product that we saw during COVID used primarily as a substitute for methadone or Suboxone to treat withdrawal, but the user was doing it on their own. They weren't getting involved with treatment clinics or anything like that. This is actually illegal in the areas in which it's natively grown, and at sort of like therapeutic or low doses actually works as a bit of a stimulant. But for some reason, at higher doses, you no longer really have that stimulant effect and you get a pure opioid agonist type effect. Fortunately, with this and the next substance we're going to talk about, we don't really ever see toxicity from acute overdose. If anything, if we're going to get someone who presents to us with any types of symptoms and kratom's involved or tianeptine, it's almost always withdrawal. They've just decided to go cold turkey. They can't get any more, can't afford it anymore. So it's typically the absence of taking the substance and not, kind of replacing it with some other opioid with the induced withdrawal that we tend to see. Tianeptine gets a little bit of play. Kratom did. These are unregulated products in Arizona. You can buy them at gas stations. You can buy them at head shops, liquor stores, things like that. This one has the stupid moniker as being gas station heroin. There's nowhere near the potency. No one's dying from this stuff like they used to from heroin. I think that's just clickbait by the news. No one, again, professionally calls it gas station heroin outside of the media or social media. So call it what you want. Tiana, Zaza, those are some of the brand names. But tianeptine is a prescription antidepressant that's used in other countries. And similar to kratom, has one mechanism of action at sort of its low or therapeutic dose. But when you go into the supra-therapeutic range, you start to get these opioid-like effects as well. And so I'm just illustrating, kratom and tianeptine as possible substances you might hear about or come across out in the field. Again, very unlikely you're going to see acute opioid toxidrome from an acute exposure to this. More often than not, we're going to see withdrawal-related effects. And those symptoms of withdrawal, opioid specific, and I'll counter this or contrast this with our ethanol withdrawal towards the end. These are never life-threatening symptoms. They can be massively uncomfortable, and we can have both induced or precipitated withdrawal. Induced is just the absence or removal of whatever the opioid is that patient was maintained on, providing whatever clinical effects they were going for. But you take that away, or if you give a product like Suboxone, if you took Suboxone too close to using some full agonist like methadone or fentanyl, you will absolutely precipitate withdrawal, or naltrexone or naloxone, the full antagonist for opioids. These can be quite agitated patients. A lot of times our fentanyl users are also concomitantly using methamphetamine. So you remove the inhibitory effect of the fentanyl, and now you've got maybe an agitated patient from withdrawal, maybe an agitated patient from methamphetamine, or maybe an agitated patient from both. So it goes fentanyl, naloxone, ketamine seems to be the nice triad of what a lot of our patients seem to experience when they come to us. And again, it's trying to find that delicate balance of what's the right dose of naloxone to keep yourself safe and to get that patient back to some reasonable state so you can deliver them appropriately to a healthcare institution. Stimulants, methamphetamine, hands down, is still the king here. We occasionally see cocaine. We might see PCP quarterly, we think. There are some novel amphetamine products, this methylone, pentylone, butylone, and ethylone. These are products that are starting to appear in the drug supply. We don't have any idea why. Whether it's a contaminant, whether it's a byproduct of the manufacturing or some new manufacturing process of methamphetamine. But methamphetamine at the end of the day is just, again, so ridiculously inexpensive. Just like fentanyl, it's very unlikely going away anytime soon. We have some other products. We have some plant-based stimulants. But again, whether we're talking some of the prescription products here, over-the-counter products, illicit or plant-based, as products that can cause this sympathomimetic toxidrome, they all have this common mechanism of increasing catecholamines. So norepi, epi, dopamine, and serotonin to produce the sympathomimetic toxidrome. So review of systems, these are usually awake, agitated, hyper patients. They can be hyperthermic, they can have seizures. They often have pressured speech. And we kind of contrast that to garbled speech with one of the other toxidromes here. We've all heard pressured speech. It's when your mouth is pushing out 40 words when your brain's really only wanted to do 20 or so. They're just talking a mile a minute. It's nuts. But, we can see some mydriasis, tachycardia, hypertension, again, hyperthermia with, usually diaphoretic flushed skin. That becomes, again, just like the eyes with opioids, we don't always see diaphoresis with sympathomimetic toxicity. The really dry, arid conditions here allow for sweat to evaporate off the skin really quickly. A lot of times these are dehydrated patients, so they're just not going to have a lot of excess fluid to lose insensibly via sweat. So there's always the possibility these patients could look non-diaphoretic at all. But nevertheless, these patients tend to look pretty consistently just hyperdynamic from that excess amount of catecholamines. And our treatment after ABCs, in addition to cooling and or control of that neuromotor, neuropsychiatric agitation with, sedatives, is essentially kind of really, all that we generally need to do, at least out in the field. In the emergency department, we might switch over to barbs. We'll definitely tube them if we need to and put them on sedation, propofol, etomidate. We don't do sucks. I don't think you have sucks. You probably use ROC or VEC. Sucks is metabolized by some of the same enzymes that might be blocked here. So, and then there's some other adverse events as well. And then cocaine's kind of a unique one here. And we'll kind of come back to other drugs that can prolong the QRS on the 12 lead. But cocaine, can also, along with, myocardial ischemia and vasospasm, also prolong the QRS on the 12 lead that we would address with, 1 to 2 milliequivalents of bicarb IV push. Sedative hypnotics, probably the most common one that's out on the street, alprazolam, Xanabars, things like that. There are a few novel benzodiazepines, bromazolam, atizolam. We are very rarely picking those up. We don't really think that there's some new emerging benzodiazepine that's out on the streets. But certainly the combination of some of the clinical effects that you get from benzos along with opioids, has this like additive synergistic effect to cause more complicated outcomes in users of both of these products. We can see similar clinical effects with those using alcohol. There's a couple of plant products as well. But again, it doesn't matter what product we're talking about here. The common mechanism of action to produce these clinical effects is agonism at either the GABA A or the GABA B receptor, which sits on the chloride ion channel complex to produce our, toxidromic symptoms. These patients can look opioid toxic with some distinct differences. We won't see any ocular or pupillary changes, and unlike opioids, which are going to cause really profound, like muscle flaccidity, hypotension, bradycardia, and hypomotility in the GI tract, we tend not to really see those effects with a pure GABA agonist ingestion. There's a couple of exceptions in there, but really respiratory depression becomes the hallmark symptom. So sometimes it's not very easy to distinguish, the respiratory depression from a benzo from that of an opioid. But obviously, the naloxone is going to reverse the respiratory depression to some extent with the opioid, as obviously it will have no effect whatsoever for sedative hypnotic. There is a reversal agent, flumazenil. You don't carry it. We don't give it. There are some places that do. But the concern, just like with naloxone causing withdrawal in opioid dependent users, flumazenil can cause precipitated withdrawal in our GABA agonist dependent patients. Now, the concern there is these can be potentially life-threatening symptoms, and shouldn't say really symptoms. It's seizures. It's seizures from precipitated withdrawal that aren't going to be as readily treated with benzodiazepines because we have a benzodiazepine antagonist on board if we've given flumazenil. So for the most part, the management of these patients is entirely just supportive ABCs, oxygen, tube, and just kind of watch until they ride it out and metabolize the drug and do better. So pure GABA agonist ingestions tend to have less severe respiratory depression and tend to do overall better with less bad outcomes than our fentanyl patients. There are a couple of sedative hypnotics that I want to just kind of highlight here. GHB, we don't really see GHB much anymore. It's kind of a party drug, could also be used by bodybuilders. There is actually a prescription product that's out there called sodium oxybate or Xyrem. This is a very potent GABA B agonist, and sort of the typical symptom progression we get with these patients is they take a dose, they go down, they're intubated, they're in the ER, maybe up in the ICU, and just a few hours later, 2-3 hours later, they self-extubate. I happened to see this in Fort Lauderdale when I was in one of my years of training. And the moment that happened, we all instantly knew what the patient had had. Obviously, this doesn't come back on the drug screen with any efficiency. So we just kind of made that diagnosis based off of the clinical course the patient had. We tend not to see withdrawal from this produce as bad of symptoms in terms of like seizures, things like that, refractory seizures, like we would with other GABA agonist withdrawal. And we can treat this with a baclofen taper for those who are presenting, after acute toxicity with GHB withdrawal. Can do quite well. And then there's phenibut or phenylbutyric acid. This is another supplement product. This was discovered, in Russia as an anxiolytic antidepressant. It's kind of a mixed GABA A, GABA B agonist, so similar to what we see from benzos or from GHB. We see this with some regularity. It's going to look just like a sedative hypnotic. They're going to be lethargic, maybe bradypneic or hypoxic. Generally well tolerated, though. So just like with all the other GABA agonists, it's just supportive care, no reversal agent, just ABCs. And this one really doesn't fit here. It doesn't have a toxidrome I can put it with, but methoxetamine. This is a ketamine derivative, and ketamine and these NMDA antagonists can look like sedative hypnotics, but their mechanism is completely different than GABA A or GABA B agonism. They're NMDA antagonists. So is dextromethorphan. Believe it or not, the cough suppressant has a very similar clinical effect like this. But, we'll get patients who, like when they do ketamine, they want to go to the K-hole. That's sort of the edge of just before passing out from ketamine. They're looking for this dissociative hallucinogenic effect from this product. They can be pretty agitated. They're usually, though, pretty lethargic, pretty down, pretty amenable to whatever it is you want to do. You probably still can have the emergence reaction from this, just like you can with ketamine and kind of what classically we associate with PCP. PCP is the derivative from which ketamine comes from. Ketamine's about 10% the potency of PCP. That's how ketamine was discovered. Because of the ill effects PCP users were having as a prescription drug in the 50s. So just so you're aware, MXE or methoxetamine, treatment's completely supported. These tend to do quite fine. Just a couple more toxidromes, and we'll take a quick break here. The anticholinergic, antimuscarinic, apart from withdrawal or the opioid toxidrome, this is probably the next most frequent one we get calls on, and typically relate to patients intentionally taking diphenhydramine. That's generally the classic drug that's going to produce this toxidrome. So Benadryl or any of the first generation antihistamines, antipsychotics will do it too, antidepressants, specifically the cyclic antidepressants. The muscle relaxer cyclobenzaprine will do it, atropine, benztropine, belladonna, scopolamine, hyoscyamine, hyoscine as well. We've got some plant products, Jimson weed, that grow natively throughout the state. But again, irrespective of what we're talking about, these are all antagonists of the acetylcholine neurotransmitter, specifically at peripheral and central muscarinic receptors. So again, we can see some similarities between this toxidrome and the stimulant toxidrome with some notable differences. And I highlighted during the stimulant toxidrome that you might not necessarily see diaphoresis because of the environment out here. These patients are classically very dry. They will have dry axilla, dry mucous membranes. A lot of times they're doing some lip smacking because their mouth is so dry. but otherwise neurologically, they're going to look relatively the same: awake, agitated, delirious, hyperthermic, potentially seizures, tachycardic, hypertensive, but also very notable. They're going to have very significantly diminished bowel sounds and decreased urine output, or specifically urinary retention. And that becomes one of the principal symptoms we find that drives agitation that's refractory to sedation. So we can provide these patients, 2, 4, 8, milligram rounds of lorazepam, and they're still going to be jumping off the walls. So we'll grab a little ultrasound, do a bedside bladder scan, and see that they're holding 500, 600, 700 milliurine, put in a Foley, and they just chill right out. So this is one of the toxidromes where we say plastic is definitely your best friend, whether it's a Foley or an ET tube, if they're just so agitated. Your sedation's just not going to get you where you need to go. Plastic, plastic, plastic. This is that other toxidrome where we can see the conduction disturbances on the ECG. So prolonged QRS and potentially both QRS and QTC prolongation. And, just kind of an over-the-counter substance that we kind of sort of see in fluctuation present to us is this combo product, Coricidin HBP, that has chlorpheniramine, which is one of the diphenhydramine analogs. It's a first-generation antihistamine, along with dextromethorphan, that NMDA antagonist. So we'll see this in like teens and 20-year-olds who want to abuse some readily available substance to get properly high. Probably not the cheapest thing, but it's pretty bonkers. So they will be classically antimuscarinic with those dissociative hallucinations from the dextromethorphan. So usually, just sedation as necessary, benzos, whatever it is you've got on board, ketamine can work too. But, unless they're having conduction disturbance, that prolonged QRS, which predisposes them to unstable tachydysrhythmias, seizures, hypotension, they typically can just be managed quite supportively. And so there's our treatment algorithm. Benzos, we do have a reversal agent that we'll use in the hospital, albeit very frequently, because there are some contraindications to using physostigmine. And we found this out kind of the hard way. There were numerous cases of sudden cardiac death when Pfizer was administered to patients in whom we later had predisposing factors like conduction disturbance or previous seizures that the physostigmine seemed to exacerbate. They would have poor outcomes from. And then we'll just wrap this up here with withdrawal. We talked about opioid withdrawal, and we've kind of touched on, GABA agonist withdrawal with flumazenil in the GABA agonist, but really the more likely scenario of withdrawal is going to be ethanol withdrawal. Ethanol still being a GABA agonist. This can be potentially life-threatening, primarily because of the seizures produced by withdrawal. And it might not necessarily be the seizure that produces the fatal outcome, but someone seizes, falls, hits their head. These patients are oftentimes with cirrhosis and coagulopathy. They fall, hit their head, have an ICH, and, then move on to have a very, very poor outcome. Just like with opioid withdrawal, where we want to replace that full agonist to get control of the symptoms, we're going to do the same thing here with a full GABA agonist like benzodiazepines, lorazepam, diazepam, chlordiazepoxide. Depending on the state of the liver, we'll choose one of those agents over the other. Phenobarb has definitely come back into vogue in most hospitals, most emergency departments, to help manage the acute effects of alcohol withdrawal. So again, just kind of be aware, these patients can definitely look exactly like a sympathomimetic type patient. The good thing is when we go down the treatment algorithm, whether we're talking withdrawal, GABA withdrawal, or a stimulant toxidrome, your management still ABCs, cooling, and then sedation. So despite there being some overlap between these toxidromes and the ultimate, wrench in it all, where rarely do our patients present with just one reason for the symptoms they have, the treatment tends to be relatively uniform and not necessarily so unique that you're not instinctually going to think of that type of drug when we're dealing with the patient that we've got here. So Despite relatively new substances being added to the sort of illicit street market, fentanyl, methamphetamine, not going anywhere anytime soon, and there doesn't really appear to be some new novel product, maybe save xylazine, that is really dramatically making some sort of an impact on how we approach our patients. So really sort of recognizing what symptoms a patient has and how we can best categorize their symptoms into the various toxidromes really can help target the type of therapy as you're going through your review of systems and the different algorithms that you have available to you so that you can make the most targeted approach with whatever therapeutic you want to give that patient. We run the opioid assistance and referral line. I do have some information up here. So during the break or after the second lecture, please come up here. I've got some individual naloxone too. I know you're just starting a Narcan leave behind program, but these are just single dose for yourselves. Like I carry a couple with me just in case. You just never know. Give it to, take a couple if you want, one for you, one for a spouse, one for the kids, whatever. And then there's some handouts here in the middle that kind of review the toxidromes that we have. So you have a little pocket guide, but the OR line is a 24/7 hotline that's run by both of the poison centers in Arizona. That is a free, confidential 24/7 resource for any opioid related issue, whether that's telling people where to get naloxone, how to use it, how to identify opioid toxicity, when to safely give naloxone, or connecting these patients with any variety of outpatient treatment resource that might exist. So grab that. And if you don't mind, take the post test and we'll come back in like 5 minutes, 6 minutes, something like that. We'll knock out this last one. And yeah, if you could do the post test, that'd be super awesome. Thanks.